So liposomal daunorubicin and cytarabine, a drug that we initially knew as CPX-351, the principle is that there is an optimal molar ratio, which is 5:1, that produces optimal killing of the leukemia. That's been shown in the laboratory. It's been shown in animal models. So this drug is precisely that. It's a liposomal encapsulation of the same cytarabine and daunorubicin that we use in the clinic. But again, the liposomal encapsulation maintains that ratio constant and directs the drugs into the leukemic blast in the bone marrow. So the concept was that it'll produce a more effective way of delivering the drugs and more effective killing of the leukemia. So there were initially a couple of randomized phase 2 studies, one in frontline and the other one in salvage. And these two studies showed that there was a trend for a positive outcome, improved survival, improved event-free survival for the patients that received the liposomal daunorubicin and cytarabine compared to the patients who received the same drugs, but freely, the way we had been giving them for many, many years. And interestingly enough, in the frontline study, in a pre-specified subset analysis of the patients with secondary AML, it showed a particular benefit there. So that led to a randomized pivotal trial of patients with secondary AML. That's treatment-related AML or an AML evolving from a myelodysplastic syndrome. These patients were randomized to receive either CPX-351 or 3+7. There was an age limit between 60 and 75. And they were offered 1 or 2 cycles of induction. Patients who achieved a response, they received 1 or 2 cycles of consolidation. And the primary endpoint was overall survival. And this study showed actually a significant benefit in overall survival. The median survival was 9.5, 9.6 months with the CPX, compared to only a little bit less than 6 months with the standard chemotherapy. And that, of course, was accompanied by an improvement in the response rate. The CR rate was 37 versus 26% in these two treatment arms. And the drug was very well tolerated. It didn't cause any more toxicity. The early mortality was, if anything, less with the CPX-351. And then we've learned that the patients required fewer hospitalizations. They were able to receive more of the treatment outpatient. So many other benefits. So that made it a very valuable drug for the patients with secondary acute myeloid leukemia. And the drug actually has been approved for this indication. And an interesting subset analysis is that of those patients who achieved a remission and then went on to receive a transplant, they did better if they had achieved the remission with CPX than if they achieved the remission with standard therapy. That suggests that those responses were better, were deeper. We didn't have MRD assessments for this study, but it would suggest that you actually did get a deeper response. So again, a very valuable drug for right now for patients with secondary AML. There are multiple studies looking at adding targeted therapies to the combination, bringing it to younger patients, bringing it to de novo AML, et cetera, to see if it can expand the benefit to other areas.